Hello, everybody, and welcome to AUR's online Grand Rounds. I'm Tessa Cook. I'm the current president of AUR, and I'm delighted to have this phenomenal group of speakers and moderators here this evening. This is the Razor-sponsored event, and we are honored to have Dr. J Cavallo speaking today about using data to inform academic radiology practice. Thank you to Dr. Forman and Dr. Regina Hooley, who will be the moderators and provide expert commentary. And as the event goes on, if you have questions, please put them in the Q&A box, and the team will be happy to answer them. So Dr. Forman, I hand it over to you.
Thanks very much, Dr. Cook. And it's really a pleasure to introduce J Cavallo, who I've been fortunate enough to know for over a decade now, who came to Yale after doing his undergraduate studies at Tufts and then going to SUNY Stony Brook, where I went to medical school, where he graduated with great distinction, and then proceeded to do his internship at residency within the Yale New Haven Hospital Health System, and eventually did our EMBA Healthcare Leadership Fellowship, which is a degree-granting MBA program at the School of Management, combined with 2 years of emergency radiology, proctored attending level work. And then has quickly risen to a medical director role in our department, working within both medical informatics as well as under Dr. Regina Hooley, our vice chair for clinical affairs. And this talk really is part of, at the nexus of the type of work that he does in our department to help inform academic practices using real-time data. So I'm looking forward to hearing his presentation. As we've mentioned, we will take questions from you as soon as possible, and we're looking forward to a vibrant conversation. I should quickly let Dr. Hooley just introduce herself, really. Let me just let her do that first rather than me introducing her. But as I said, Vice Chair for Clinical Affairs. Do you want to say a couple of quick words?
Oh, sure. Well, it's really great to be here. And of course, I have a great team working with Joe in clinical affairs. And of course, Howie is always a good consult. So I'm happy to be here and learn as well. Thank you.
Thank you. All right, Joe, take it over. Are you able to share screen?
I will get on that. Verify that you guys are seeing the presentation slides, correct?
Yeah, looks great.
Okay. Thank you all for the introduction, and thank you to AUR for hosting me. We're going to be talking about why and how we can use data to inform our academic radiology practice. So, we're going to start today with a very brief overview of some of the concepts and terms that are important to the context of physician productivity that we're going to be discussing today. Then we're going to go into some of the recent changes to the radiology field and radiology job market over the past few years that have disrupted certain workflows. And then we're going to finish with how we can effectively use our imaging and operations data to better inform our management decisions in radiology, helping to address some of these market-related challenges and other issues within our practices. So we're going to start with the actual determinants of revenue to a hospital system. Again, this is just a very brief overview. There are really just 5 main drivers of revenue determination. We have payer mix, patient mix, and case mix, which are largely determined by the geographic region you are serving. Beyond that, some practices will have control over collections, either complete or incomplete, depending on their relationship with the hospital, whereas other practices are going to be completely siloed from that side of the business. And so out of these 5 drivers, we really only have significant control over the physician productivity lever when we're addressing our practices. So this is just a reminder that there are 2 different types of physician payment models. There is a true salary model, which is predominantly seen at the VA and similar state-run facilities. And then there's a fee-for-service model, which most of our academic practices are going to fall into this model. That is despite the fact that most academic practices generally employ their physicians through salary. And so this talk is not about which compensation which model is better or even how to set compensation, but rather we're going to look at how can we best assess productivity to better allocate resources and inform decisions within either of these models. So relative value units, or RVUs. Everybody's probably at least superficially familiar with them, but we're going to speak quite a bit about them today. So I want to give a basic overview for those that are not as familiar. RVUs, or relative value units, are assigned for each CPT code, and they attempt to factor in things like physician effort, the cost of operations or practice, malpractice expenses specific to a specific location. Once that number is produced, it is then subject to various modifiers. Beyond the modifiers, there are additional incentives that can affect the payment, such as alternative payment models, or APMs, and merit-based incentive payments, or MIPS. And that's the other MIPS, not the maximum intensity projections that you're probably all more familiar with. And here's a complete overview of the actual payment scheme that incorporates RVUs. This is not meant to be completely informative, and it's not meant to overwhelm you. It's just to highlight the fact that when we discuss RVUs in this context, we're really just referring to work RVUs. And as you can see, it's a small portion of the overall payment calculation. RVUs are far from perfect, and you could spend an entire lecture on them. But for our purposes, the value comes in providing a standard measurement for comparison, both between radiologists and between different practices. So now that you have a brief overview of how payments are calculated, this slide just demonstrates some of the trends in payment over the past 3 decades. You know, if we start with the top column here in 1995, we're looking at 3 exams that are common in radiology: chest X-ray, abdomen CT, and brain MRI. You can see that over the past 3 decades, the growth in these numbers has been negative to the tune of about 12 to 16%. And if we adjust those numbers for inflation, you can see that our reimbursement per exam has gone down almost 60%. And so, while that number seems pretty steep on its own, if you consider that inflation-adjusted income for radiologists has also gone up over that time, the other way that you can look at this chart is that as a field, we have seen remarkable increases in efficiency over the past 30 years to overcome these trends in payment. And so we need to identify areas where efficiency and support can be increased, and where exam growth may be starting to exceed reasonable volumes. So if we think of technology in the context of our prior slide, as we mentioned, our field has made incredible gains in efficiency to not just keep up with, but exceed those historical trends that we just looked at. PACS and improving dictation software would probably be the 2 most important historical examples. And I would wager that the increasing adoption of AI is probably going to be the next big example in terms of increasing our efficiency as we move forward. Of course, this increased productivity has to be balanced with safe reading rates, appropriate turnaround times, and high-quality patient care. And it's important to remember that there's always going to be inherent variability between our different radiologists, our different subspecialties, but we should be trying to aim for equal workloads when possible. These QR codes are references to 2 papers that I pulled out when I was looking at some of the literature here. One was, is there a safe reading rate? The literature would suggest that we have not been able to ascertain what a safe reading rate is over a specific period of time for radiologists. If it does exist, we have not been able to pinpoint it. That being said, we do have to be conscious about our turnaround times for patients and our employee satisfaction. And the second QR code references a paper in Radiology that looked at physician burnout from the perspective of the radiologist. But we are not just widgets. We're not just cogs in a machine. As members of academic medical centers, our institutions provide additional crucially important services and goods to both the medical establishment and the communities that we serve. medical research, training and education of students, fellows, residents, and others. We provide very highly specialized care that may not be available at community practices or other facilities. And we provide a great public good, predominantly in the form of emergency and trauma care for, in many cases, underprivileged populations. And so now let's transition a little bit to the post-COVID radiology market, which saw a vast increase in teleradiology and remote work. I've highlighted, 5 key takeaways from the past few years. One was the recovery and expansion of imaging volumes, new reading workflows due to the changing workforce, increased communication requirements. We're having this discussion via Zoom, and you're probably all very familiar with it, but also between radiologists and trainees, the subsequent impact on trainees in terms of shifting workforces and changing reading habits, and then compensation changes where some certain subspecialties became highly sought after due to shortages in most recent years. So to summarize some of these new challenges, we had rapid fluctuations in imaging volumes in the job market. A lot of sections or departments ended up over or understaffed. We had new reading patterns with more remote capable faculty and more teleradiology positions. And we ended up with more cross-specialty radiologists reading between multiple sections, probably also at least partially in response to over and understaffing. And so what are our goals when we refer to data-informed practice? First and foremost, it is optimal patient care. We're all here in order to provide the best possible care to our patients. Beyond that, we want to create an equitable environment for our physicians. Significant disparities in effort can lead to strife and negatively influence culture within a section or department. Beyond that, overburdened physicians can potentially negatively impact the trainee experience. And then we also want to better anticipate our needs as we look forward. How can we identify areas or time points where our staffing is going to need adjustments? And we need to do all of this within the context of ensuring a profitable practice. Our former CEO had a saying that she often quoted, and it was "no margin, no mission." And it basically refers to the fact that without a well-run patient-facing operation, all of the research, the education, and the public good that are the other core values of our academic enterprises can't be supported. And so where do we get this data? There are 4 main groups or buckets that I'm going to define here. The first is billing data. This is obviously the most directly related to our revenue. It is a good overview, but it can be very noisy, and it also does not inform about individual shifts. The EMR or report data is what I find to be the most complete data set. It allows you to look at both scanner level and radiologist level data. And it's an important distinction because these are not always the same. Some academic centers or practices may outsource certain reading responsibilities or certain time periods to teleradiology groups. Then we have work list software. This is probably the best source for getting a snapshot of current conditions. How are our turnaround times looking? Are there backlogs? Sort of questions like that. And then dictation software. This is by far the most granular. It's very specific to each individual radiologist. And you can see specific reading patterns, how certain attendings function with and without trainees. And then the main downside of this, at least with some dictation softwares, is it's a very clumsy user interface to poke around with that data. And as you can see with the bidirectional arrows here, this is all shared data. It should be used to inform one another. And it's also important that you are checking your data summations and data conditions, making sure that the work list is matching with what you're predicting from the EMR or dictation and vice versa. Just a quick slide here about analytics tools. Most hospitals and academic centers will have some sort of business intelligence software. We use predominantly Tableau. I also find that it's useful to have spreadsheet software for doing additional manipulation of raw data or answering specific questions about items that you may not have pre-set up within your business intelligence software. So ensuring accuracy. As mentioned previously, the EMR data is the most complete, but the analytics tools will need appropriate APIs to communicate both with the EMR and scheduling software for full integration. We do have dedicated IT staff that can help with this, and that's a really big plus. You may need to use a complex combination of filters to fine-tune the accuracy for specific attendings or shifts. That EMR data can allow you to filter down by ordering departments, finalizing providers, specific exam codes or patient age and time to really get the best accuracy. The work list data sets and dictation logs can provide an excellent set of ground truth if you need to manually audit smaller sample sizes to verify your overall accuracy. And by playing around with these filters and doing select manual audits when necessary, we've gotten our large scale data operations to be accurate within 1% of what we consider ground truth. And the last and third point here is that when you're setting these things up, you're also going to have to decide how you want to handle ancillary staff like moonlighters or fellows that are also signing as attendings. This will potentially impact how the data looks in certain sections, and whether or not you need to include them is something you should address when you're setting up these dashboards. Two of the special circumstances that we ran into were predominantly a factor of the increased teleradiology shifts and remote signing, and the off-shift signing. Traditionally, our dashboards were set up to be filtering amongst time, and so when signing off shift, it was causing some issues. I'm not going to go into the specifics of how we solve those, but needless to say, they are solvable problems. The other one was the cross-specialty workforce, which I alluded to earlier. I will say while we're on this slide that issues like this can be dealt with in a much more streamlined fashion if you have either internal or third-party software which is set up to help attendings assign studies to a specific workday or work shift, and kind of analogous to how residents or fellows must assign all their studies to a specific attending. And so when we get to the Q&A, I'd love to hear from the audience if they use any of their core software or third-party solutions to manage this aspect of their data. So we've got our up-to-date data. We've verified that it's accurate. Now what are we going to do with it? Benchmarking is going to be crucial to setting up efficient operations. And we need to define our starting point. We need to identify an accepted standard. And once we do that, we can start to assess the progress of any changes that we make to inform our practice. This slide is about the AAA-RAD dataset. In addition to getting reference points from peer institutions, we use the AAA-RAD dataset as kind of a standardized metric on which we can make comparisons with. This is a productivity assessment compiled by and for academic institutions. The reason why we find this valuable is because it allows us to compare to a large number of institutions that operate in a similar fashion, all of whom place a value on education, on research, on interdisciplinary conferences, and other non-interpretive tasks that are not going to be adequately captured by the RVU-based data. It also provides section-level specific data so that we can compare an ER section with other ER sections or a neuro section with other neuro sections. It's important to remember that there is a wide variability in productivity between different subspecialties based on many factors, but predominantly the types of modalities they read. For example, you wouldn't want to be comparing your neuro section with your pediatric section because neuro is very MR heavy and pediatrics is very plain film heavy, and there's a corresponding discrepancy that comes out in the RVUs. So here's an example of the type of benchmarking data that you could be obtaining from a data set or creating on your own based on a combination of informal references and standardized data sets. I'm not including the upper portions here, but we're showing percentile efforts between the 40th and 70th percentile. And so what you see in the middle column here is yearly RVUs per section X. And what this is basically defining is what a full-time clinical radiologist would be producing in terms of RVUs over a year of work. And so for the 40th percentile, it would be 10,350 RVUs. It's important to remember that a lot of our staff work less than 1.0 full-time equivalent. For example, in our practice, most academic radiologists are at 0.8. And then, this yearly RVU data comes in handy doing certain calculations, but it's also very helpful to translate this yearly data into something that's more manageable or tangible for the individual radiologist. And you can do that by converting it into the RVUs per workday or shift. And this is basically done by taking your yearly RVU data and dividing it by the number of clinical workdays or clinical shifts that somebody would be working at the full-time equivalent at your institution. Just as a note, I'm going to be using the terms days and shifts throughout the presentation, but they're essentially synonymous here and simply referring to units of work. So we have our data, we have our benchmarks. Now, how do we guide productivity? There's three general options here. One is self-regulation. You can leave it up to specific sections. If left to their own devices, some sections will self-regulate, but some will do it better than others. You could have volume-driven guidelines where estimates of cross-sectional or plain film volume versus other modalities can be provided for a reasonable shift expectation. Or now with some of the newer worklist distributors, you can actually target a specific exam or RVU goal. And so I know I'm breaking a cardinal rule of putting a spreadsheet on a presentation, but we're going to walk through it slowly. This is actually one of the best ways to kind of visualize how you can put this data to use here. We have what I would call an RVU matrix here, and we're looking at a section that has 6 attendings, attending A through attending F, and it has 5 shifts, shifts 1, 2, 3, 4, and 5. And so if you look at any given row in this matrix, what you're looking at are the specific averages of RVUs produced for a specific attending. If you're looking at a column, you're looking at the output for different attendings on a single shift. And so by doing this, you can start to see, clear variation or clear patterns that can emerge. Looking at the averages, here you have attending averages on the right, in the right-hand column. And in the bottom, you have your shift averages in the bottom column. And so you can, quickly see that, okay, shift 5 is our busiest shift. You can start to see where there are outliers. For example, I have highlighted attending A working shift 1 because they're more than 25% off the average for that shift. You can, do a lot of different calculations with this. It's important to remember that you're not striving for completely equal distribution here. What you're trying to identify as outliers, maybe attending A has a standing conference during shift 1, or maybe shift 5 is at a busier time of the day. But once you start to organize data like this, which you can do either in your analytics software or with third-party spreadsheet software, it can start to give you a better idea of where are potential pain points within a given section. So next, we're going to move into a few case studies. These are kind of based on stuff that we've done in our department, but they're general case studies. This is example data from a section who thinks that they would benefit from an additional shift. So we have 9 shifts in this section. We're not showing attending level data because right now we're concerned about is the section as a whole overburdened. This is 28 days worth of data, but when you do this exercise in real life, you're going to want to look at longer time periods, right? Because we all know that there's seasonal variability. You want to be looking, you want to make sure there hasn't been any significant expansion or imaging responsibility changes over the time period you're looking at, because that can play with the data. But for our intents and purposes, 28 days gave us nice numbers for this example. So, here we have the number of RVUs worked over that 4-week period for the whole section. It's 12,900, and it resulted in actual average RVUs of 56.5. And so if we say for our hypothetical section here that we are attempting to benchmark to a 50th percentile level, we would want or expect that our per shift RVU output would be closer to 50, right? And so in our case, we're at 56.5. We can see in more detail that some of the shifts are averaging well over 60 RVUs per shift. And so not only is the average high, but some individual shifts are even further above the 60th or 70th or even 80th percentile if we were to show all those numbers. And so we can be pretty confident here that we're going to need to add a shift. It's important to remember that adding a new shift or a new rotation can take many forms. It doesn't necessarily have to be something that is added every day. It could be an extension of a current shift in terms of making the hours longer. It could be something that works, every Monday and Wednesday. Some sections have significant outpatient volume over the weekend, which results in a heavy reading load on Monday. Maybe you just need an extra shift on Monday to help catch up. Those decisions are kind of need to be made on a one-to-one basis. It's kind of up to the section chiefs and department leadership to ascertain the most effective way to allocate extra resources. For the example here, we're going to make it simple, and we're going to say that we're basically going to duplicate shift 8 rather, because it's the busiest shift. And if we were to add another shift like shift 8, what it's going to do is it's going to increase our total number of shifts over that 4-week period, but all the rest of the data stays the same because we're presumably going to be imaging the same, we're going to have the same imaging habits. And so that's going to pull our average RVUs down to something closer to what our benchmark was. Now, it's important to remember that just because the section as a whole is now at average, it doesn't mean it's going to fix all the disparities in average RVUs per shift, and you may have to do some workload distribution or redistribution. So do a second case study here, also requesting a new shift. We'll use a smaller section. This one just has 6 shifts. And so, doing the same exercise, we can look at our actual RVUs. We're at average RVUs over that 4-week period of 50. And for simplicity, if we use the same benchmarking or target data, we're kind of right around where we want to be, right? And so in this case, it's probably not necessary to add an additional shift here. But if you look closer at the data, you see that there's a significant disparity between shift 2 and shift 5. And we are all human. It is just human nature for us to remember our most busy days. And so everybody's going to remember these 59 days. They're not really going to remember as much the 39 days. But this is an example where you can dive a little bit deeper into the data, and maybe there are certain imaging responsibilities that you can offload from shift 5 over to shift 2 to create a more equitable workload distribution between the shifts within a section. And now let's move on to how we can use data to help anticipate expansion needs. First step is going to be trying to get an accurate assessment of new volume. This can be historical imaging data if you're taking over a pre-existing facility. If you are building a new facility and expanding into a brand new market, you can try and make projections that are based on similar facilities already under your management. When you're going through this exercise in real life, it's also important to consider organic yearly growth. If you look at historical imaging data, but you don't anticipate, natural growth, assuming that there is some capacity on the facilities and scanners, you're going to be a little bit behind the 8 ball by the time you get to your new responsibilities within 6 months, 12 months, 18 months, or even further out. Once you accurately assess the new volume, you need to figure out and allocate where that new volume is going, right? The new volume is not going to be equally distributed across your sections, especially depending on the type of facility which you are going to start working in. And then once you do that, you can use the combination of this new data to create updated section projections and decide, is this a situation where we're going to need to add additional shifts, add additional rotations, or even add new hires? And so, this will be our expansion case study. And you'll notice that we're looking at slightly different numbers here because we're looking at sections rather than shifts. So we're just going to walk through this slowly. This is we're looking at 3 different sections here. But since we're looking at section level data, rather than look at, the RVUs per workday or shift, it's going to be more informative to look at the RVUs per FTE, which is actually just another way of phrasing that yearly full-time equivalent RVU data that we showed earlier, and which I have in the right-hand column as a reference point here. So we have our baseline volume, and then we've gone ahead and estimated our new expected volume of 36,000 RVUs, and we've looked at our historical imaging data to allocate which section those RVUs are going to be distributed amongst. And you can see section A is going to get 15,000, section B is going to get 5,000, and section C is going to get 16,000. So now we're going to add our benchmark yearly RVU data for the sections with our new expected volume, and we're going to have our updated projected yearly RVU data. And now we can start to factor in, our total full-time equivalents have not changed yet, right? We're trying to decide whether or not this is going to be something that we need to change in the future. And so when we look at the RVU per FTE in the new projections, we can see that section A has significantly increased their RVU per FTE, and it's not shown here because I just kept the 50th reference for simplicity's sake, but you have to take my word for it that section A would now be at the 70th percentile. And so if in our hypothetical department we're still aiming to benchmark around a 50th percent number, they're gonna need either additional moonlighting or additional shifts to help make up this extra volume, right? And if we look at section B and section C added quite a bit more volume than section B, but they're still under the 50th percentile. However, given the fact that they added 16,000 RVUs, we know that, based on reading assignments, it probably is not equally distributed across the different shifts or workdays within section C. And so while they're still not at a point where we would think they need additional shifts or need additional hires, it may be a situation where we have to better distribute their workload, similar to that second case study that we looked at earlier. And just a few additional considerations to close out here. When you're looking at data like this, time-sensitive shifts can add a little bit of a wrinkle. If an outpatient rotation is particularly busy, that can be spread out over a number of hours for staff to catch up. But with pretty stringent turnaround times for urgent inpatient exams or urgent ED exams, the variance of those peaks and the max caseloads that you may be seeing in a short amount of time can start to become important, and that's something you'll want to look at in your data as you analyze specific shifts. So you could have an ED shift like that looks like the average volume is reasonable, but at times they're having hour or 2 hour stretches where they're reading at pretty high rates. So that's just something to think about. And then the other aspect about this is if you want to differentially weight certain work days or certain shifts based on the different qualities of those shifts. And I've listed a few examples here about remote versus on-site, teaching versus non-teaching shifts, and whether or not you want to give additional premiums for evening, weekend, or even overnight work. And these are all examples that we've had to deal with, but in the interest of time, we're not going to go through case studies on those. And so, thank you for your attention. I want to welcome back Dr. Forman and Dr. Hooley, and we will take any of the questions, and looking forward to a vibrant discussion in the next 15, 20 minutes.
Great. So the first question is, how is any of this unique to an academic practice except using benchmarks, academic benchmarks as opposed to private practice benchmarks? How do you think about the academic versus private practice issue?
Well, so that was one of the things I alluded to. Generally, in a private practice setting, if you were to look at what's an average output on a private practice day versus an academic day, it's generally higher. But there's a lot of factors that go into that, right? And so it's important to remember that when you are doing this in the context of an academic program, you're not just looking at RVUs, right? We are not numbers on a screen, and RVUs do not capture the complexity of our work as academic radiologists, right? And so that's why you want to compare yourselves to other institutions where there's also a need for teaching, a need for highly specialized patient care, research. These are just they're inherently different models. And so whereas private practice may say, this is, we need you to read 12,000 RVUs in a given year for this section, and you either have to hit that or your compensation is impacted. I don't think that's the way that you would handle this in an academic practice. Again, you're looking to guide your decision making. You're not using these RVUs as a make it or break it decision point without a greater context.
Can I chime in? I
Yeah,
think that these days, the gap between academic practice and private practice is much smaller than it was maybe 20 years ago, as many private practices are being, are consolidating. And now a lot of people in private practice are salaried employees of large organizations, similar to how we are salaried at our university practices. And likewise, on the flip side, our productivity as academic radiologists has gone up considerably over the last 20 years or so. So I'm not saying it's equal to, but it's much closer to what I believe private practice often is. But in academics, our motivation is different, and we have a lot more variables. We have teaching, we have research, we have scholarly projects, presentations, and in private practice, there's some of that, especially in the large organizations. I see some of that more now than before, but their main driver, of course, is revenue and overall compensation in general. That's the main driver. So it's a lot closer now, though, than it was before.
And I will say it's also not completely apples to apples comparison between the data for private practices and academic practices, because we may have, and every institution will be slightly different, but we may have many more patients with complicated histories. They may be a far more acute patients. We may be reading far more ICU plain films compared with outpatient plain films, so that the case mix and the acuities can look so different that I'm not sure that if you took a private practice radiologist from a different state reading 13,000 RVUs, that they would find it as easy to read 13,000 RVUs in most academic practices. So there's a lot of variation. And I think we also have to be cognizant that our practice is different from the other 81 practices in ARAD. The next question is, about ARAD data and whether it's publicly available or not. So I'll just tell you from my own inside view of this, I'm a member of ARAD. I'm a full paying member of ARAD. I do not have access to ARAD data through my ARAD membership. I don't know precisely what the restrictions are to that. But what ARAD does do is they share with the administrators of the practices that participate in the survey the ARAD data for use by the practice. So there's a user agreement that exists between ARAD and the 82 practices that participate and are members, but it is not necessarily shared with every ARAD member. And again, I'm an ARAD member as an individual member. I do not get the survey myself. I only get to use it through the practice. Other questions that we can answer? I have other questions I can raise, but I want to see if there are other questions that people have before I start asking questions. Oh, here we go. A question, given that RVUs are imperfect, and they are very imperfect, I appreciate you saying that, how do you try to account for potential distortions, overvaluing some types of exams activities while undervaluing others? So let me just start off my point on that, and that is that they are imperfect. Like, you know, even if you're all reading MRIs of the brain and everybody's reading MRIs of the brain, if I'm only reading MRIs of the brain on post-operative patient with recurrent disease, and you're reading only MRIs on the brain with patients who've had a first seizure, you may have very different looking productivity levels. But I'm curious to hear what you think, Joe, across the practice here and just your own experience.
Yeah, well, I agree. The RVUs are very imperfect, but I think one of the things we count on is that they're consistently imperfect. And so while they're going to distort numbers within specific sections, you would expect that those distortions are going to be similar at other academic practices. And so when you're comparing or trying to compare apples to apples, you know, to continue with Howie's analogy, or example, you know, you want to compare one neurosection with another neurosection because they're going to be dealing with the same particular case mix that splits up, you know, what percentage of outpatient MRs versus complicated inpatient MRs. But yeah, it does introduce a lot of disparity between different sections, and that's where a data set comes in handy, because you could have a section with lower RVU producing examinations that's working very hard, and they come out with a lower yearly number than another section who could be working, you know, not as hard but producing more RVUs, to take an extreme example.
And let me just add also, like, it's my opinion, just an opinion, that because there's such variation between institutions, that I don't take too seriously the difference between 45th percentile and 55th percentile, because in general, there's going to be a lot of variation between practices. But certainly between 20th percentile and 80th percentile, I think ARAD data can be extremely helpful in showing you those bigger trends. I don't know if you want to add anything to that, Regina, before I move to the next question.
Sure. I mean, it is imperfect. And as Joe mentioned, it's better when you compare across sections and the subspecialties. And the good news is that ARAD has over 80 institutions contributing into the data. So it sort of washes out, I think, that variability.
Yeah. So the next question is, do you think that RVU-based shifts are causing academic practices to look more like private practices?
Do you want me to take that one, or
You either can. I mean, I don't.
I would defer to you two with a little more experience.
I think that, as I mentioned earlier, that the gap is narrowing when it comes to volume and the overall sort of structure, where private practices now, the traditional private practice model where you own your equipment and you own your freestanding outpatient center and you take only insured patients, and you collect a lot of revenue, is really rare these days. And most of those older partners have sold off, and You might be working for private equity, you know, in disguise, under guise. I mean, let's face it. So, and we know that their number one goal is revenue, right? So, I think that it's closer, but it's still very different, where we do have different incentives. And also, as mentioned, our salaries have gone up considerably over the years as well, with our increasing productivity. So I think that often our salaries are not as disparate with the current private practices, particularly in employee-based, you know, radiologist private practice.
Yeah, I mean, I do think that we've seen a convergence in terms of productivity for shift. If you look at private groups right now, other than owning the equipment, their salaries are converging with radiology groups. There are several examples locally where we're paying better than private practices, and in some unique circumstances, private practices may pay better than Yale. And I think what needs to be pointed out is that if you're a pure clinician in an academic practice, you do look very often like a private practitioner. Most of our physicians have academic time on top of that, which allows them to have less clinical productivity and more time for academic output. Another question related, very related, is, are RVUs correlated with academic scholarly productivity to create incentive schemes? And I will just tell you myself, I remember, I'm trying to remember his name, but he was at the University of Maryland, and I forget where he is now, but he had come up with sort of an academic RVU measure. There are other practices that have used academic RVU measures to try to figure out how to judge academic time, but our systems are very imperfect for valuing academic output on a financial basis. The NIH itself caps compensation for time at a level that is about 40% of what we pay our radiologists right now. So it is an imperfect enterprise. I think what Joe's talk today has done is at least given us metrics and numbers to be able to use to inform the best distribution of resources that we currently have. I have a question for you. If other people have questions, they can ask it, but I have a question for you. And that is, I'm aware that Epic and even PowerScribe, I think, are able to tell you how much your RVUs are for a given shift or something like that. And I'm wondering, like, how reliable those figures are and what influences whether they are or are not reliable.
So you're correct. There are ways to get RVU data out of both of those programs, but they do have to be set up in advance. You know, for example, in our practice, we do not use PowerScribe's RVU counter. We reference the data directly through Epic, which gets it from Medicare, I believe. And an important distinction is that RVUs are based on CPT codes, not radiology exams. And so it's an imperfect science. There are certain radiology exams that are not easily correlated with a specific CPT code in Epic, at least in our instance. And so when we initially tried to set up this database to really get accurate data, one of the things we had to do was tabulate and identify all of the specific IMG codes that did not have an appropriately linked RVU value within Epic. And so for those, what we do is we either have to use Medicare data or make a best estimate based on similar exams to manually assign an RVU for those exams. And being that IMG codes can change, not infrequently, it's something that we have to do as an exercise on an annual basis to make sure that we're staying as accurate as possible.
I have a question for the two of you, and that is, the models that you presented are really based on what we've done over the last couple of years and sort of tweaked and adjusted. That seemed to work for our practice. We didn't have at least I didn't have a roadmap of how somebody else did it. or manage their volumes and caseload and projecting the future. How applicable do you think that what we do would be applicable to another practice, or are there, shared sources or available sources to see how other academic practices manage their caseload and volumes?
Yeah, I mean, I mentioned at one point, I'd love to hear how other institutions or practices have approached some of these problems. I do think when you go through a time period of significant change, like we've seen over the past few years, there are, the perturbances can be greater than in a steady state work environment. And so, just from a human resources perspective, leaders are going to want to make their employees as happy as possible, and that goes for a department chair, but it also goes down to whoever is heading a section. And so incentives may not always be aligned when something happens like that, and I do think it can be helpful when you introduce data like this to better gauge some of the changes that may need to be addressed, that have just kind of happened organically or have been made through prior decisions that were not as informed by data.
Yeah, I find when I stay in touch with a good number of people that are either currently or recently section chiefs at other institutions. And I do find that most leaders in academic institutions are aware of what sectional productivity looks like, how it compares with ARAD data, and what type of internal benchmarks they need to hit in order to justify hiring more or expanding services. So and I think it's very telling that 82 institutions, and by the way, if you look at the list of institutions, you'd be hard pressed to find an academic institution not on the list. I can't find one. In fact, it's very telling that 82 institutions participate in this survey every year. Our departmental administrator spends a lot of time importing the information, because it's not just RVU data, it's also salary data every year to make it useful. And I think it's one of the most well-attended sessions that is carried out every November at the ARAD meeting, which also tells me that this is very, very useful. But I think, if Joe wanted to have a second career, I think he could go around the country having a consulting practice, because every practice will be different, and you would want to modify this somewhat for each practice. So in the absence of, oh, go ahead, Joe, I'm sorry.
I was just going to say, and I think that's, again, one of the big differences between academics and private practices. There's going to be much less variability in what these numbers mean to a private practice than when you're trying to interpret them in the context of an academic program.
Yep. So we have one last question. How do you prevent cherry picking of outpatient clinic studies over cancer post-transplant follow-up? It sounds like a very specific question, and I feel like all of us and probably everybody on this call has our own analogy of this. Why does this matter or not matter to you, Joe?
Well, I think you alluded to it earlier, right? This goes back to the imperfection of RVUs. There's no way to discriminate in the actual effort that is required between, within a single exam code, right? And so one of the drawbacks, if you were to try and just give everybody an RVU number or exam number to target for a specific day, is that you immediately incentivize this kind of cherry picking. And so there are multiple ways around it. One is you don't give benchmarks like that. You just try to manage from a global perspective and ensure that you can create a sectional or department culture where everybody is, behaving professionally and reading at appropriate levels. And the other one is you can rely on work list distributors that manually make these decisions about what you are going to read for you. And so if you have a robust work list distributor such as that, it's harder cherry pick. Obviously, a lot of these programs will have ways that you can, I'm sure you could say, oh, the exam's not ready to be read, or any number of other ways to try and wiggle your way out of reading that complicated cancer case. But there's probably a way to limit that. And, all these software programs audit, every click you make on your workstation. And so if cherry picking was really that big of a problem, there are ways that you could figure out who's doing it and how to address it.
Can I add just one other strategy, which some of our other sections do? You guys work in the ED, so you don't really have this ability to do that. But basically, what shifts you're assigned on during a day, one could be like heavily outpatient, and you're just doing outpatient reads, and then the next day you could be doing the inpatient reads, or it's a half day if the inpatient is too much. You do half day of inpatients, and those are the harder patients, and then another rotation would be outpatients. And then
But there's no question that we, even in our own practice here, have witnessed evidence of cherry picking at times. And this is not just a healthcare industry problem. This is like every industry has experience with how individuals will cherry pick or game the system otherwise. And it is, in my opinion, one of the most important things is establishing community norms and being able to develop a culture where people work together and row in the same direction, rather than feeling like they are alone in the boat rowing for themselves. So it gets way beyond this talk specifically, but there's no question we have seen evidence of this, and we are sympathetic to the questioner's question there. We are just about out of time. I want to just first of all thank Razor for sponsoring this, Joe for putting this together in very, very short notice and doing an amazing job presenting this, and my colleague Regina for joining us and being an amazing discussant. So thank you all for doing this and for the great questions today.
Thank you, everyone.
Yep, thank you, and have a nice evening.